I think we're good to go whenever you're ready.
Okay, and then lastly, I'm having a hard time getting the chat down. Are you guys seeing the chat or, oh wait, here it is. Now I can get off, never mind. Okay, so good morning. We're gonna do July's case reviews. I thought that there were some interesting cases, as always, that our EMS team has been involved with, and I hope that you guys find something educational from the information that the next 5 cases. Maybe. All right, so as always, the information that's discussed here is confidential and private. It's protected by HIPAA, so please be responsible by not sharing this information or discussing details that allow the patient to be identifiable. For case 1, EMS was dispatched to an unconscious party. They arrived to find a 72-year-old female at her private residence. She's altered. PPE was appropriate and above based off of just the initial information. Primary surveys, this patient is responsive to painful stimuli. She's unoriented. Her airway is open but appears to be labored, and that there's some evidence of trauma but no active bleeding. Initial vital signs were taken shortly after patient contact with a pulse of 60, blood pressure 109/73, respiratory rate of 20, but a room air sat of 78%. The only past medical history that's available later on in the course, I believe it wasn't immediately, is that she had a psychiatric history, and that the provider had documented that the sister couldn't contact them today. And interestingly enough, she also tried to contact them 5 days prior and had sent out one of the sheriff officers to go and assess the patient and her husband, which they found the patient and the husband were fine. But today she couldn't get a hold of them, and they find the patient to be unresponsive or to painful stimuli, and they can't find the husband. So care starts, again, as a reminder, underlying times is going to be first patient contact, transport, and then arrival at the hospital. So they arrive finding the patient to be altered and hypoxic, placed her on a non-rebreather, 15 liters. They get a set of vital signs, which I just reported to you guys. And I apologize, it was actually a little bit later. It was 15 minutes after initial patient contact that they got a full set of vital signs. They placed her in spinal precautions and placed an IV. And let me see if I can get there we go. They noted that when they got to the house that the lights were on in the hallway. It's about 6 o'clock in the evening, and they found the patient upstairs under her bed, only visible from her neck up. She was moaning, and that they noted that her physical exam was that she had swelling to both of her eyes and a jaw deformity. They had pulled her out from underneath the bed, noting that both her knees were swollen, and they checked her blood glucose, it was normal, and due to her trauma, her hypoxia, and her combative nature, they elected to protect and control her airway with RSI. They pre-oxygenated her to 98%, gave her etomidate and succinylcholine, and then at some point during that time, either during or prior, they did get a 12 lead. They noted that they couldn't get, they used DL or direct laryngoscopy the first time and were unable to get intubation placed on first pass. So they tried a second time with video and a bougie and placed a 6.0 ET tube successfully. They leave the scene, but prior to leaving the scene, they find the husband dead on scene. There's not a lot of discussion about if it looks like foul play or if there's trauma, just that they found the husband. And they transport her with a full trauma activation. They get another set of vital signs. Only difference now is that she's no longer hypoxic, otherwise stable vital signs with the second set. They sedate her with Versed and fentanyl and get a third set of vital signs, and then sedate her a few more times and arrive on scene. The picture on the bottom right is not of the patient, but to give you an idea of maybe what they had experienced. And one of the things I think I might have glossed over is that besides the bilateral eye swelling, they also noted jaw deformity. So in reviewing this case, I thought that their documentation, the time that they took to talk about what was the reason why they were even on scene because of the sister, and the weirdness of her contacting sheriff's officers about a week earlier because of not able to reach them, and then just the strange scene dynamics. The husband's dead on scene, the patient's under a bed on the second story, lights are on, doesn't look like she fell down those stairs. They took C-spine precautions. They looked for alternate causes for alternate mental status, and I thought that the decision to RSI and then getting pre-RSI vital signs, which is really important to optimize hemodynamics if the patient is hypotensive, and why they were unable to get the first pass intubation successfully. What they actually documented extensively about the changes that they did to ensure its second pass success, and then obviously confirmation of ET tube and sedation. That the decision to make her a full trauma, given the limited information in the suspicious scene, as well as getting a 12 lead for thoroughness. You know, as for, I wrote in here that maybe placing an adjunct like an OPA or an NPA if the non-breather was not. I'm sorry? Can whoever had the question repeat?
I don't think that was a question, Jackie. I think that was somebody just logging in.
Okay. And just as a reminder, if no questions, make sure you're on mute so we don't hear any feedback in the back of the in the background. And then using an adjunct if a non-breather, otherwise using a bag valve mask with an adjunct if necessary to pre-oxygenate or to normalize hypoxia. This particular crew had documented, at least the way that I read it, as one attempt, but missed attempts need to be also documented. So this is a 2-attempt intubation. And then I'm not exactly certain, and I don't know if any of the crews that were on this scene would be willing to discuss, but the use of a 6-0 as opposed to a 7 or 7.5 or 8-0. I imagine that because she was a difficult airway initially, that we dropped down to a different, one of the things that they dropped down to a different ET tube, a different size or a smaller. And what they had documented was that her mucous membranes, her posterior pharynx was so dry and almost kind of desert-like that they couldn't see the anatomy. The secretions were making the posterior pharynx difficult to gauge where they were. So they took the ET tube out. They put a little bit of saline in there to try to moisten or to hydrate the posterior pharynx, and were able to successfully identify the anatomy after doing so. So as for her follow-up in the emergency room, they noted that she was hypernatremic, that she might have had a urinary tract infection based off of some of the findings on the urine analysis, and that her drug screen was positive for benzos, but probably from the Versed that she received for sedation. She had a pan scan, and they noted that she had this left-sided jaw hematoma and maybe pneumonia, so she was treated with antibiotics. In the first day of her hospital course, they noted that she was pretty unresponsive despite letting off the sedation, so they got an MRI of her brain and noted that she had suffered multiple small strokes, but not the reason for her altered mental status. She spiked a fever, they did an LP, and they identified that she also had meningitis. On hospital day 5, she's still not improving despite the antibiotics and the resuscitative measures that she had underwent and was continuing to be treated for. They've decided to further investigate what they might be missing, and they noted that that left jaw hematoma was actually an abscess, and they believe that it was from a dental abscess. They contacted the sister, who had said, yes, indeed, that the patient was complaining of tooth pain and had seen a dentist about a month earlier. By hospital day 9, so they drained the abscess externally. By hospital day 9, she still wasn't getting any better. They evaluated for other etiology for her presentation, and they noted that she actually had a thrombosis in her cavernous sinus bilaterally, and that she also had an abscess deeper into her parotid and mastoid space. So given her clot, they started her on heparin. Hospital day 11, they took her to the operating room to drain the abscess that was deeper with oral maxillofacial surgery surgeons, and by the post-op day 1, she was improving significantly. So let me try to get this out of the way. Okay. I thought it would be a good time to talk about something that's pretty rare, cavernous sinus thrombosis. It's exceedingly rare. They have a difficult time determining or guessing how often this actually occurs, but they're estimated to be as up to 1.6 people in every 100,000 people each year. Usually it's septic, but it can also be aseptic, so it's usually associated with facial infections. Central facial infections would be infections between if you think of it as like the outside of your lips to your nose, that triangle is considered your central facial infection. So dental, sinusitis, pharyngitis. Patients usually present with complaints such as a headache. They might have some periorbital swelling, maybe both eyes, maybe chemosis, which is the conjunctiva edematous. They might complain of pain, and they might complain of vision changes like double vision. Physical exam findings might be a fever, altered mental status, obtunded or lethargic. They may have a seizure, although that's very rare, in that 90% of these patients will present with eye findings, either physical that you can see or that you can demonstrate with an extraocular exam. And the treatment's antibiotics and anticoagulation. The image on the right is give you guys an idea of where the cavernous sinus is. So the image on the left side is an axial view where the cavernous sinus is depicted by the yellow bar in the central part of like the cranial fossa. And then the image on the right is your coronal view, cutting through the center of the skull, giving you an idea of the blue representing the cavernous sinus, and that it's surrounded by blood vessels and nerves, so that's why it might affect the eye exam. To give you another bit of information is that the cavernous sinus is responsible for collecting collecting blood from the brain to bring it back to the heart. So if there's impingement or impediment of the blood flow, that's why the patients present with eye findings, because of the location, and it's almost like an engorgement of the venous outflow. So learning reviews on this particular case, this crew really had a lot of protocols that they were navigating through, and I thought they actually did a fantastic job, especially given such little information. So they were looking at altered mental status, maybe abuse and treatment, C-spine precautions, RSI, trauma system activation, and I thought that given all of the stuff that they had being limited, but even if they had more information, they did an excellent job. Any questions about case 1? All right.
What was the story again on the husband?
So all I had for EMS is that they found him deceased, and then there was many days of notes for the hospital course, and one of the hospital course notes said that the the husband was demented, and they believe that he was in pursuit of trying to get help for his wife, and possibly stressed himself out and had a heart attack, or just dropped from trying to seek 911 help for his wife, or maybe that he just didn't know what to do and wasn't actually looking to call anybody, and had just got so stressed out and so scared that it led to him having a sudden cardiac arrest. So they believe it to be, at least by the hospital notes, to be only related in the sense that it might have been him fearful for his wife.
Right. interesting note. A friend of mine who's a vascular surgeon had a cavernous sinus thrombosis 20 years ago when he was just starting his practice, and he ended up he survived it, but his ophthalmoplegia was so affected he was unable to operate for 2 years.
Yeah. And such a rare incidence of presentation too.
No.
Awesome, thank you. All right, moving on to case 2, unless there's any other questions. All right, so EMS is dispatched to a traffic accident at a recreational center. They get there, or they potentially have gotten information that this is an MCI with 3 elderly patients, anywhere from 73 to 87 years old. The patient in question is this 87-year-old female, where she's complaining of scapula, right arm, and left wrist pain, and had reported slight shortness of breath that EMS had documented. PPE used was appropriate for non-aerosolizing procedure, and they found this patient to be awake, her airways open and protecting. She has no active bleeding, and the first set of vital signs are 20 minutes after patient contact, but noted to be tachycardic, normotensive, and no documentation of her SpO2 at the initial, and as we go to the next slide, I believe there was no documentation of any of her SpO2s. Past medical history is hypertension, and HPI is that she is in a golf cart descending down a hill. I believe one of the male individuals was driving, not that that makes any difference, but she wasn't the driver. They were unable to slow or stop, and interestingly, I think when I looked at the 3 patients that were in this this golf cart, I think they were all over 100 kilos, maybe 125, so a bit of inertia going down this hill. The driver tried to avoid striking a tree, so he did an invasive maneuver, which caused the golf cart to tip and ejected all 3 elderly out of the golf cart. So the rest of this information is regarding the female. Patient contact, a set of vital signs, placement of a IV, transport without any specific activation. She was given 8 milligrams of Zofran. Subsequent vital signs show that her heart rate improves. The information about the scene is that she did not have a loss of consciousness. There's an obvious deformity to her left wrist, so she was splinted. They also put a bandage on an abrasion. I believe the documentation for placing her on nasal cannula was just subjective, but it wasn't in the procedures, and it was just documented in the narrative. They did document that they offered pain meds to her and she declined, and that the other 2 occupants that were on scene initially were reluctant or refusing transport, but then later, with coaching of what I believe EMS and family on scene, they agreed to transport with the elderly female. And I believe that they were all transported in the same vehicle, but I could be wrong. Same ambulance.
You're correct on that.
Okay. So this was reviewed by the MPD's office, not me particularly, so that's why it's just a sentence saying that at least one of the 3 golf cart accident individuals should have been a modified trauma based off of mechanism and the age of these of the patients. So case follow-up. In the emergency room, I don't know if she was roomed in a room or in the hallway, but my understanding is that it took about 40 minutes before a set of vital signs were initially obtained, triage vital signs. And they noted that she was tachycardic and hypotensive with a room air sat of 91%, which prompted this to be a trauma activation. Physical exam by the ER doctor is that she has bruising on her forehead, she has decreased breath sounds, she has left shoulder wrist deformity and a bruise to her left shoulder and wrist deformity and a bruise to her left shoulder with an avulsion of her skin to the right forearm. Based off of vital signs and physical exam, they did spinal precautions, and they elected to intubate and sedate her, one to allow for bilateral chest tube placements based off of their imaging, and to reduce her fracture, which they determined to be an open fracture to her left radius. Imaging, she did get pan scan, so an open distal left radius and ulna fracture. She had bilateral rib fractures with a flail on her left chest. She had small but bilateral pneumothoraxes, but given that she was intubated, that was what prompted the bilateral chest tubes, in that they noted that she had a large left hemothorax. She had transverse process fractures of her thoracic 1, 2, and 8 spine, in that she had a moderate amount of extrathoracic, so outside the rib cage hemorrhage on the left side, and with subcutaneous air. And she also had pelvis fracture with bilateral superior and inferior ramus fractures. So she was quite ill, despite what might not have sounded like a very good or high mechanism, and possibly a more thorough physical exam may have found some of this, as I don't believe that the rib fractures would have been at any point during the transport. So hospital course, once they determined her to be stable enough to go to the OR, they wanted to wash out her wrist with orthopedics. They got into the operating room, and she cardiac arrested. Initially, before the trauma surgeon arrived, they were able to get ROSC with a wide complex tachycardia, thought to be ventricular tachycardia. They defibrillated her several times, which they were unable to get her out of VTAC, but then I believe the second or third time they lost pulses. Trauma surgeons in the OR, so he performs a left thoracotomy, and they note a large amount of blood coming from her chest, which was due to a laceration near the lung hilum on the left side. They were able to control the bleeding by cross-clamping her aorta and her lung, but despite this heroic measure, despite intracardiac epi and cardiac massage, they were unable to get her get ROSC back. So they called the code shortly. Actually, I shouldn't say shortly, almost 45 minutes to an hour after she arrested. So the protocol that I would like to review is that if you look on the image on the right-hand side, that's our modified trauma. And based off of the mechanism of her being ejected, although it wasn't necessarily a traditional automobile, it was a golf cart, you could extrapolate it to being the same. So she was ejected. She had an open fracture of her wrist, which, as a reminder, any break in the skin overlying a joint or bone that is suspected to be fractured should be considered an open fracture until proven otherwise. So time-sensitive extremity injury. And then the paramedic judgment. So I believe that our crews did not feel that she was a modified trauma, but she did meet 2 of the other criteria that should have prompted her to be a modified trauma. And then in retrospect, which is always 20/20, she had a flail chest, she had a pelvic fracture, so she actually met the criteria for a full trauma. If the systolic blood pressure was as low with the hospital as if it was as low in the pre-hospital setting as the hospital setting, she would meet the vital sign criteria as well. But again, a reminder that small mechanisms in elderly can lead to substantial life-threatening and devastating injuries. So to have a higher index of suspicion in our elderly folks. Any questions? Concerns? Thoughts?
I had a discussion already with the paramedic and about this. The other follow-up is that the younger of the 2 gentlemen also had significant rib fractures and was admitted and kept 2 days because of his rib fractures. There was a note that he was improving remarkably, and they were surprised because of his age, but he was only 72, and many of us of that age have survived significant rib and lung injuries. But I digress. The real point on this is that the evaluation failed to find the flail chest and the rib injuries and lung injury, and but then the other indications for, I mean, this woman was well in her 80s, and so she's basically, we should probably, you know, I co-authored a paper a few years ago that looked at elderly trauma, and felt that we probably should increase the altered mentation to the fact that just having a GCS of 14 or less rather than less than 14. So 14 or less in elderly once they're over 65. And of course, we always have been doing the greater than 55 with anticoagulant medication. We should probably just say greater than 65. That we have so many people who would just have ground level falls that have a major problem with and without anticoagulant, let alone being thrown out of a golf cart. The big problem with this is I would always prefer that we overshoot on elderly in activating the trauma system, because what happened with this case is she came in code 1 and she's put in, and the nurses trust you, and the nurses trust that, well, code 1, it's not a big deal, it's not even a highly suspicious thing. And she went into the, I'm surprised they didn't send her to registration, you know. So she went into the queue and is a very, you know, when you're busy in the ED, you have to be able to push someone up the queue to make things work. So if you call a trauma activation, you get a doc and a nurse to see the patient almost immediately, if not immediately. This may have made a difference in this case. Now, that wouldn't have prevented what happened in the operating room, but it's, you know, we would have looked better no matter what.
Yeah, and I think it's a great opportunity for all of us to recognize that we need to be very careful about our physical exams on all patients, but especially our older population, and that we need to have a higher index of suspicion. I think that in retrospect, obviously that's easy to look at what the outcome was, but that we should have had a pulse ox that might have clued a bit better physical exam, a pulse ox that might have clued us into why is she not a higher oxygen concentration, because the initial one by the ER shows 91%, which would mean for anyone to kind of look into, is this underlying lung pathology? She had a trauma. This is probably going to be a traumatic, if it's not a rib fracture, it's a lung contusion, to give you an idea of how potentially critical your patient is. And then activating this as at least as a modified trauma would have been ideal for our side of the pre-hospital setting management.
Right. Agreed.
All right. So moving on to our third case. EMS was dispatched to a rollover MVC. My understanding is that this was a vehicle that, I'll talk about an HPI. So 29-year-old male, initial chief complaint is shortness of breath. PPE used was appropriate as long as they weren't going to move towards a aerosolizing procedure. Primary surveys, this patient's awake, his airway's open, but does not appear to be adequate, as it appears that the patient is quite short of breath. Pulses were present without any active bleeding, and the first vital sign obtainment of any was a SpO2 of 70%, 3 minutes after patient contact. Past medical history is unknown, and the report that I recall from reading was that this was a driver of a pickup who was trying to merge onto the highway. I believe that he had struck a vehicle that was in the merge lane, causing him to roll over, hitting the, I think the median and rolling over, I believe end over end. He was unrestrained. There was positive airbag deployment, and that it required our EMS colleagues to extricate him by the door, which I think that they document took a minute to extricate him out. In that, witnesses on scene immediately made patient contact and noted that he was awake and complaining of shortness of breath. So the belief was that he did not have a loss of consciousness. So prior to, I believe this is AMR's timeline that or GMR's timeline that I have here. So prior to transporting crew, a peripheral IV was established, and that the patient was given 750 mLs of IV fluids with that IV. A couple minutes afterwards, after patient contact, a needle thoracostomy was performed with a rush of air. This was placed in the second and third intercostal space, and they placed a second IV and then documented about another 750 cc's of IV fluids, a supraglottic airway, and that the SATs were in the 70s. I believe that a little bit of kind of making assumptions, but I imagine that the patient was pretty altered, or that his GCS allowed them to place an SGA. So physical exam, they noted that he had a large head laceration, and what prompted the needle thoracostomy was that he had absent right-sided lung sounds. They RSI'd him a few minutes after initial patient contact with appropriate drugs, and tried to video laryngoscopy place the ET tube, but due to copious amounts of blood and I believe some emesis as well, that it was unsuccessful. They elected to do an iGel after that instead of, I believe they did document that they suctioned and that they were unable to get better control of the emesis. So therefore they placed an iGel, got off scene, and went to the hospital for a full trauma activation. Vital signs noted to be just hypertensive, and the third set of vital signs en route noted that his hypoxia had resolved with a 98% SpO2 and an end-tidal of 44. They gave him post-intubation sedation and arrived on scene. And I believe, I apologize, I should have looked this up beforehand. With level one, or with full trauma activations, we aim for less than 10 minutes scene time. Is that right, Dr. Whitwer?
Well, that's in our orders. I don't think, we had a little extrication issues with that,
So
but yeah, we tried 10 minutes. I don't think anybody ever, that's one of the things we're going to have to review now that we have better data sources. But I know that Portland is reviewed at 7, and nobody ever makes a 10-minute scene time. Now that's not saying that we shouldn't have that, but that still is the American Academy of Surgeons. The ACS recommendation is 10-minute scene time without heavy extrication and problems with that. But they're never on the scene themselves, so it turns out to be a goal, but it's difficult to make, and I'm not sure. I don't think we make it most of the time. Not that we shouldn't keep trying.
So I just mentioned, because I didn't catch this when I reviewed it the first time, but 12-minute scene time and importance of making sure that we document why we didn't make a goal of 10 minutes. All right, so good on this case. I thought 2 large bore IVs, spinal precautions, identification of absent lung sounds and hypoxia leading to needle decompression, decision to RSI, and attempts to control airway secretions, but noting that this might be futile and going straight to a supraglottic airway with an iGel. And then obviously trauma designation, repeat vital signs reassessments, as well as post-intubation sedation were all the things that this crew I felt exceedingly did well on. Some of the things that I think that there's room for improvement is that based off of, I believe, I don't remember what fire service it was, but based off of the initial responding agency time and the attempt for needle decompression, it was 13 minutes. So ideally recognizing the absence or suspected absence of lung sounds on one side that would represent having, in this particular incident, having a trauma that led to it. Obviously a little bit more difficult if it was spontaneous pneumothorax, but ideally identifying and addressing that airway emergent issue during the primary survey, so within the first 5 minutes or less. And then based off of what I could see for documentation, this patient received 1.5 liters of IV fluids with all blood pressures being substantially above normotensive numbers. Going back here, we're looking at 140s and 170s is what we have for systolic blood pressure documented. And then the timing of post-intubation sedation. So obviously this was a difficult airway due to the emesis, but being mindful that even if we make a couple attempts at intubation or placement of a supraglottic airway, that we are getting our sedation meds on board before too long. Usually about 5 minutes, your paralytic is going to wear off, or either way is that this is a painful procedure and that you might still have your paralytic on board, or that you it's completely worn off or metabolized, and that you're dealing with a patient that's starting to wake up or starting to reach for your procedures and extract them from their body. So in the hospital, his iGel was replaced for an ET tube. They placed a right chest tube because they did not hear lung sounds on the right side. He developed hypotension, and they did a fast ultrasound on him, noting that there was blood or suspected blood. So he went to the operating room. In the operating room, he also received packed red blood in the emergency room. In the operating room, he underwent an emergent splenectomy due to a substantial spleen injury, and then they controlled the bleeding on his liver with packing. They sent him to the surgical ICU following his OR course, and he desatted to 28%. They were able to get his oxygen concentration up with bagging. They did a bronchoscopy to try to suction out any secretions. They noted that there was quite a bit of secretions that they thought were related to a pulmonary edema, so they gave him a diuretic and they proned him. So pretty aggressive maneuvers to try to improve his pulmonary function. They placed a left chest tube because the CT scan showed a small left-sided pneumothorax, and since he was intubated with positive pressure, that would likely increase in size. He also had substantial pulmonary contusions. During his hospital stay, he developed some seizure-like activity. They started him on anti-epileptics, and they noted that his EEG was significant for what they thought was post-hypoxic myoclonic seizures. And so his overall diagnosis was ARDS, acute respiratory distress syndrome, bilateral pulmonary contusions, bilateral pneumothoraces, a splenic and liver laceration, clavicle fracture, and his hypoxic respiratory failure, prompting EMS's aggressive airway procedures as well. So I thought this is a good time to talk about what to do when you have somebody puking or vomiting blood to the point where you can't get it under control. In our protocol, we talk about using Zofran, so maybe you guys could drop some Zofran, but in these kind of circumstances, I think it's a matter of suctioning and getting the suctioning under control. If you have the hands and time, of course, you can try someone to drop an antiemetic, but you likely are going to need to do very aggressive suctioning. And then under special considerations, head injury, increased intracranial pressure, all these special considerations are other etiologies for why the patient might be vomiting. And then as for just reviewing our protocol, I see that we also have an isopropyl alcohol swab, but this is not a patient that would benefit from trying that. This would be like some medical patient that was hemodynamically stable and Zofran wasn't working on. So you guys probably have heard of SALAD, but not this type of SALAD, the suction-assisted laryngoscopy and airway decontamination, provided by Dr. Cantu, which is an anesthesiologist. For those that have seen or heard of this, it's a great reminder for those who've never seen or heard. This is just a short 2.5-minute video.
We'll begin today's demonstration with an explanation of what I call the static exercise. I will deliberately fill the mannequin's pharynx with simulated airway contaminant until it reaches the posterior pharynx. The initial exercise is to teach the clearing of airway contaminant with a suction, as well, and to use the suction as a multifunction device, much like the use of a wooden tongue depressor to assist the insertion of the laryngoscope blade into the patient's mouth. What's important in the exercise is to lead with the suction, not lead with the laryngoscope. Otherwise, the laryngoscope's optics and video elements become occluded with airway contaminant. I'm going to begin the exercise. I'm now going to utilize the suction. I'm overhand gripping like a taser, suction. I'm going to utilize it very much like a wooden tongue depressor to open the hypopharynx to assist the insertion of the laryngoscope blade. I see airway contaminant in the posterior pharynx. I'm now going to train that. I'm going to lead with the suction. Lead with the suction. I'm going to identify the laryngeal structures as the epiglottis. The tip of the laryngoscope is now in the vallecula. I'm going to expose the larynx. I'm going to suction airway contaminant from the just below the larynx. The next maneuver is crucial to continue to be able to drain the airway during airway management. I'm unable to place my tracheal tube into the airway with the suction in the position that it occupies right now. So I'll need to change the suction catheter position. I can do this either by pushing forward the laryngoscope and moving over the suction and then placing it into the opening of the esophagus, or alternatively, I can remove the suction and place it on the left side of the laryngoscope blade with placing the tip into the upper esophagus. The suction now literally holds itself. It's out of the way for tracheal tube delivery, and I'll complete the intubation by placing the tracheal tube into the larynx, removing the stylet, inflating the cup.
So it's possible that this particular crew had used this technique, but if not, it's worth trying, especially if you're having difficulty in placing an ET tube. So the next point I wanted to talk about was, with this case, is permissive hypotension or delayed hypotensive resuscitation. It has different names. And the goals is to balance avoiding exsanguination of the patient, but maintaining pressures high enough to maintain perfusion to the organs. So avoiding any disruption of an unstable clot due to elevated blood pressures from crystalloids that we have. And overall, that would be to avoid further hemorrhage control. The image on the right here kind of talks about with the pathophysiology of trauma and bleeding, where the patient has a traumatic event, they develop hemorrhage, they develop coagulopathy. Our resuscitation can, especially if we over-resuscitate a patient, can cause coagulopathy to be more impaired, leading to further hemorrhage. and we're trying to gauge resuscitative crystalloids in the pre-hospital setting so that we are avoiding shock, which is going to again lead to coagulopathy and further hemorrhage. So it's a balance between the two, and most of the time a lot of the pre-hospital and hospital settings are aiming for systolic blood pressures above 90 before administering crystalloids, or preferably blood, but trying to get the patient to the operating room to control the hemorrhage before diluting out their clotting factors. This comes from a study out of Houston in 1994. At least the permissive hypotension initially comes from this study that talked about immediate versus delayed fluid resuscitation for hypotensive patients, but the study was originally for penetrating trauma, and it's been extrapolated to blunt trauma as well. And in this study, it was non-blinded, semi-randomized prospective study. They looked at patients that had penetrating trauma, and they had enrolled about a little under 600 patients that had the penetrating trauma to the chest and hypotension with blood pressures below 90. They had an immediate and delayed resuscitative group based off of even and odd days, and their overall outcome favored delayed resuscitation with a mortality approximated at 70% for our delayed resuscitation versus our aggressive or immediate resuscitation at 62%. So the patients that fell under the delayed resuscitation received no fluids unless they became more hypotensive, and then the immediate resuscitation was as typical, 2 lines, fluids wide open, right from the pre-hospital setting to the emergency room. Our protocol talks about shock and that we want to control any external bleeding, and then giving up to 2 liters of crystalloids to maintain systolic blood pressures of 90 and MAPs of greater than 60, as well as addressing or considering any evidence of volume overload and optimizing mentation, assuming that mentation would be related, altered mental status would be related to hypotension or underperfusion. Any questions? All right, so I'm going to quickly go. I have 2 more cases to talk about. We have 8 minutes. So EMS is dispatched to a breathing problem. They get to private residence with an 83-year-old female with a past medical history of CHF. Actually, I meant to delete that. Anyways, she was complaining of shortness of breath. They had appropriate PPE. In fact, presuming that she was going to decline potentially because they actually had HEPA filters. She was awake, she was labored for her breathing, but her airway was open. There was no active bleeding. Initial vital signs showed that she was a little hypertensive to tachypnic with a SAT of 92%. Her past medical history was cardiac and pulmonary, making it difficult to determine what was potentially the etiology of her shortness of breath. And that additional information provided was that she was defibrillated 1 week ago without clear explanation of the circumstances for that. She, initial presentation was pale and diaphoretic. She was leaning forward and too weak to hold up her own weight. She was speaking in 2 to 3 word dyspnea, and she couldn't tolerate laying down. Lung exam noted that she had crackles in all of her fields, and she had no other complaints besides just shortness of breath. She had an IV placed. Her glucose was elevated, but not the source of her issue, in that they started transport. Shortly after starting transport, she became hypoxic. They tried some nitroglycerin, and they actually, I didn't mention it, when they heard the rails, they placed her on the CPAP. So they were very aggressive about getting her on positive pressure ventilation. She didn't quite respond to the nitroglycerin in the CPAP. They noted that she became more lethargic, and she had no purposeful movement, so prompting EMS to go ahead and move forward with RSI. They were successful with placing an ET tube, an 8.0. They gave her post intubation sedation, being mindful to start with pain first with fentanyl and sedation second with Versed, and they arrived to the hospital. I thought that this is a great example of all of the complexities and tools in our toolbox for pre-hospital and doing an excellent job of treating, escalating treating, reassessment. So you can see decision-making I thought was great. Care provided was excellent. Documentation was also excellent, especially her changing involving picture. They used PPE that was appropriate, and they upgraded. They actually had a little lower level, I think it was a surgical mask, and they upgraded to, actually no, they had no gown, and they placed a gown on when they started to move towards aerosolizing. And then the only thing, it sounds bad, just call it the bad, but consider additional dosing of nitroglycerin if the patient's blood pressure can tolerate it. In the emergency room, she received Lasix. She had a CT scan to evaluate for pulmonary embolism, which was negative. In the hospital, they diagnosed her with heart failure exacerbation. They did an echocardiogram that showed an ejection fraction of 30%. 10 days earlier, she had an echocardiogram that showed 40%. And then with this echocardiogram, just in addition to the ejection fraction, she had severe hypokinesis, which was new from her previous one, as well as stable severe mitral regurg. They continued to diurese her and were able to extubate her on hospital day 1. She's doing really well. And then that defib 1 week ago was actually, she was cardiac arrest and had achieved ROSC, complete neurological recovery. And then they placed an ICD to try to prevent any other arrhythmia degeneration for her. So our protocol in regards to respiratory distress with pulmonary edema, mindful not to, or if possible, keep their legs down, because once you raise the legs up onto the bed, you decrease that gravity and make it more difficult for them to oxygenate potentially. There's more detail to that, but I'm trying to keep in your guys' time frame. So if you want to talk more about it, we can talk about it offline. And then if a patient's blood pressure can tolerate nitroglycerin and you're highly suspicious for pulmonary edema, redosing every 3 to 5 minutes. All right. Quickly, any questions on case 4? All right. So last case, not a lot to discuss, so it should be pretty quick. So EMS was dispatched to a cardiac arrest. They are dispatched to a 34-year-old male who's unconscious and unresponsive. Appropriate PPE utilized based off of chief complaint. They find this patient to be unresponsive, apneic, and pulseless. They document I think it was Fire's vital signs for the first set of vital signs. They confirm that the fiance reports that this is a COVID case or COVID diagnosis recently, and he was diagnosed 12 days earlier, was feeling better the day before, and was just sleeping. She kept on checking in on him, thinking that he was just sleeping in, and noted that he was unresponsive, and she had last seen him alive or awake 1 hour previously. Prior to transporting ambulance arrival, an IO was placed, an iGel was placed, and Lucas was initiated. They placed another IO, missed a peripheral IV, and gave a dose of epi. Glucose was normal. They document a pulse ox of 79%. Subsequent doses of epi were given for a total of 3 rounds, and they exchanged out the iGel for an ET tube a little bit over 12 minutes, 13 minutes, and they document another SpO2 of 57%. For documentation, we want to make sure that we're putting zeros for the things that we really are assessing. So heart rate should be zeros, and with all of these SpO2s. And honestly, when we're checking for pulses and deciding to give that second or third or fourth epi, that we should be putting in vital signs that were not present that we checked. The patient was asystole throughout, and medical control was contacted requesting for at least 20 minutes of ACLS care for this patient. So I'm going to briefly talk about our protocol determining death in the field. If the patient's asystolic throughout the entire encounter, then 3 cycles of ACLS for asystole are appropriate. If EMS, so second bullet point with the second red arrow, if EMS feels that we potentially doing any rounds of ACLS or shortened rounds of resuscitation would be appropriate, then they can call medical control to inquire if resuscitation can be ceased earlier than 3 rounds. A lot of agencies look at the data on our improved ROSC and our resuscitative efforts brought to the pre-hospital setting, and many agencies are moving towards 30 minutes of resuscitation in the field unless ROSC or VFib or VTAC is sustained and potentially transporting earlier than that. So with us, we're doing 3 cycles. In addition to, with a young patient, 34 years old, despite COVID, we would want to give that patient every potential possibility for treatment and resuscitation. So a few things that could have been utilized in this patient is to use bicarb. Given that he was asystolic upon arrival, he probably was in arrest for longer than our fresh cardiac arrest, as well as calcium gluconate to help facilitate cardiac squeeze once it was sustained. I don't think I have any other questions about that case. And Lynn, or Dr. Whitwer, would you add anything else to that case that we need our crews to be aware of?
No, that's only that basically we are still at our normal treatment of cardiac arrest to date. This is the first case of cardiac arrest that we have proven that we knew was COVID positive. We have every case of every cardiac arrest that we've had ROSC or that we've transported to the hospital because of ROSC or sustained VTAC has been tested, and to date we have no positive COVID-19 cardiac arrest, so that essentially we are dealing with cardiac arrest as per usual despite COVID in the population. So we are not doing anything different than what's in your protocol now. Now the protocol for managing asystole, if you knew that the patient was COVID, is exactly the same as the protocol that's in your chart for the average run-of-the-mill cardiac arrest. So, and Dr. Gadbois pointed out that we have a tendency, when you contact medical control, we will definitely probably ask you to be a little bit more aggressive and try other things in a young patient, much more so than an older patient. And that's exactly what happened in this case, that the physician requested that at least 20 minutes of resuscitation be attempted. And in reviewing this, I would have added at least bicarbonate to this case, if not calcium as well. I believe that the glucose was checked, so that was.
It was.
Okay. So that's my contribution to that.
All right. Well, I looked at the comments. I didn't see any that needed. Mr. Johns couldn't see an image at 9:18, but hopefully you guys, him and everyone else could see images. But if you guys don't have any other questions at this time, I guess we'll sign off. As always, my contact information is here. So if you have any questions or concerns about case reviews or future calls that you might have, feel free to reach out to any of us in the MPD office. All right. Thank you, guys.
Great. Thanks, Jackie.